Okay, something just came in.
Done. You
got it?
You can start, yes.
Okay. Okay. Greetings, David Sarver from Birmingham, Alabama, and have a short little guide to what I term superior orthodontic aesthetics, which is really an all-encompassing thing of macro, which is the face and how you appear, mini, which is your smile, and micro aesthetics is your teeth, your tooth shape, shade, and a number of variables like that. One of the objects of the little webinar we're going to do today is to sort of give you an eye of how we treatment plan. And so what I'm going to do is, give you just a little introduction. It'll be a little bit like a book. We'll go through things sort of a step at a time. So I hope you will enjoy it. One of the first things we wanted to talk about was the current concepts about smile art. Published on Smile Art, 15 years ago, and there are still quite a few misconceptions about it. And so maybe this will help clear that up for you in terms of how to approach that. This is the original definition of the smile art, which is the curvature of the maxillary premolars, cuspids, and incisors in relation to the curvature of the lower lip. The original paper said cuspid to cuspid. I have expanded it all the way back, and I'll demonstrate that in a couple of cases as we go. So smile art, it doesn't have to be on the lip, it has to be parallel to it. And then I'm going to address another issue on that one a little bit later. So classification, consonant, which means that the curvature of the occlusal plane and the lower lip are consonant or parallel to each other. Don't have to touch, just need to be parallel. Flat, obvious in the picture. Reverse, where it's the other way. And this is obviously the smile art, which leaps out and gives not a very pretty smile. And I've added one classification, and that is called excessive, which is where the lower lip covers the incisal edge on smile. And that's a different bale of hay there to deal with, which we won't cover today. Its conceptual evolution is fairly important. It started in prosthodontic literature in 1958. So this is not a new concept. It's kind of new to orthodontics and really something we're talking about a lot, but it started out as a denture concept because dentures were made, they were flat looking, and Frush and Fisher figured out that that was not a natural appearing slide. Halsey in 1970 published in the American Journal of Orthodontics. So it appeared in orthodontic literature in 1970. And in this study, what Halsey found in his master's thesis at the University of Washington in St. Louis was that 33% of the cases they treated in their clinic ended up with flatter smile arcs at the end of treatment than they did at the beginning. Didn't really propose what might be causing that. I will. Next, Jim and Mark Ackerman, father-son, they published in 1998 in the Clinical Orthodontic Research Journal, a morphometric analysis of the posed smile, where they talked about the smile arc and a more quantifiable analysis of that. Didn't get a lot of attention, kind of not the most widely read journal. But they found that the same sort of thing, 1/3 of their patients had flatter smile arc, but they recalled patients who had never had treatment and found that 5% of the people who never had treatment still had smile arcs which flattened, which indicates that there may be something more than where we put brackets or whatever. Here's an important article published out of Ohio State, Kerr, Chan, Fields, Beck, and Rosenstiel, and it was in the Journal of the American Dental Association. And what they did was they looked at smile aesthetics and the variability of smile arc, buccal corridors, tooth proportion, gingival display, all those sort of things. And what is really important, the acceptability of what variations in smile arc. This was also published in Orthodontics and Craniofacial Research and also in the Journal of the American Dental Association. An important article by Parekh compared lay evaluation of smile characteristics of smile arc overwhelm the buccal corridors. In other words, as Dr. Field says, the smile arc triumphs, you know, on everything. It's a deal killer. If you have everything right, but the smile arc is flat, it lowers all other standards of measurement of what lay people think of as a good smile. So it is indeed proven to be very important. Now, you know, when we talk about smile arc, we very often talk about the anterior view. We talk about the front 6 teeth and all that, but I take a different view of that. I take a 45-degree view and look at the smile arc in its entirety, rather than just the anterior, but from posterior to anterior. We'll touch a little bit on that as we get into this presentation. But this is a case in which the teeth are retroclined, and my task is, obviously, as an orthodontist, we'd line that up and they'd come out like this, and that would tend to flatten the smile arc. So that's why that view is an important view to me for you to take. So what I've done is I've gone back and I've looked at what are the elements that make up a smile arc to us. Number one is head position, how we take our photographs. I'll clearly demonstrate that to you. Number two, variability of lower lip animation. We'll demonstrate that as well. Three, dentoskeletal growth pattern. In other words, it's not just a tooth position issue. It's growth pattern, which, you know, then kind of accounts for that 5% of patients who flatten without any kind of treatment at all. Tooth shape and attrition, maxillary tooth size excess, maxillary incisor proclination, and broadened arch form. Obviously, we're not going to have time to cover all these right here, but you know, they are published and you will be able to find them. But that number of things are what I've come up with as, here are all the things I see that influence the smile arc, and things that we checklist when we're looking at a flat smile arc, for example. Could be one of all these things or a number of them. Which then leads to, what methods do we have to improve a non-consonant smile arc? Number one on the list to me is specific bracket placement. I think 1/3 of our orthodontic cases get flattened because we put them on the same time, same way, every patient, each time. It's not individualized to that patient's smile. Clearly, to me, that is the number one cause. Occlusal plane control, orthognathic clockwise rotation, IPR and cosmetic incisor shaping, uprighting of flared incisors, and obviously cosmetic dentistry. All those are methods which can improve a flat smile arc. Well, when I first published on this, interestingly, a paper came out, a 2-part series in the Journal of Clinical Orthodontics, that said smile arc is a fallacy. Now, every new concept should be challenged, and I'm not, you know, feelings not hurt, but I do want to present to you the importance of head position. Came out saying smile arc was a fallacy. This is out of the journal and says, although smile arc is supposed to follow the cant of the lower lip, changing head position changes that. All right, and so that brings us to head positioning, and the repeatability of our photography and record taking is critical to analysis of smile arc. So this is an example I use of a young lady I treated who, if I have her head held down, she's got a great smile arc. Hold it up a little bit, it's a little flatter. Hold it up even further, even flatter. If your staff member, who may be the one taking your pictures, doesn't recognize this as a potential problem, then you just have to take the picture yourself, is what I've discovered. Well, okay, smile arc doesn't exist. Well, I'll use this example. You know, if we change head position, then the smile arc changes. Well, I use this as an analogy. If my staff member takes a perfect picture of a buccal segment and it has class 2 windows in it, I have an option. I can say, you know, I kind of ended up with a little class 2 window in that case. Or what I can do is say, let me borrow the camera. I'm going to move around to the front, take it from a different angulation, and all of a sudden they're class 1. We all know that as orthodontists as we take pictures. What's the point of all that? Well, the point is pretty simple. The solution is that if the smile arc doesn't exist, then how did you take a picture of it? So in other words, it exists. It depends on the angulation of the picture that you take of it. And we all know of photographic anomalies that we see in literature. Okay, so this is about variability of lip animation. This is, you know, a person who has slight asymmetry to his smile curtain. He shows more tooth display in the posterior than he does in the anterior, but this is a flat smile arc, and it just simply doesn't match the curvature of the lower lip. Next, this is actually an employee of mine who does not show smile curtain, you know, de-elevation of the lower lip on the right, left side, but does on the right side more than the left. A very V-shaped curvature to the lower lip might be kind of hard to be parallel to that. And then the really accented curvature to the lower lip, it would be a really horrible looking smile to try and get perfectly consonant with that smile arc. So that is kind of to bring up that, you know, I tell people, look, smile arc is a guideline. It's not a rule. That, you know, as dentists, we're trained in dental school that everything has to be within an angstrom of whatever. And so that's beaten into us all the way through orthodontics, that the lower incisor has to be at 93 degrees to APO. But let's make sure that everybody understands that smile arc is not like, if you end up in treatment with a flat smile arc, there's profile to consider, there's extraction, non-extraction, there are so many other things to consider that I like to emphasize that, look, it's a guideline like everything else, that I would not want to get a consonant smile arc in that patient's lip orientation. Palatal plane, occlusal plane orientation. This is a picture of a lady who's was a surgery case where the posterior maxilla was down, anterior is up. No amount of bracket placement is going to take care of that. That is a skeletal issue. It's on an adult. It's going to require orthognathic surgery. If it was in the child, growth modification, TADS, all kinds of things, but in the adult, surgical alteration is what we need to do. And this is also one of the reasons that I take the oblique smile image. It shows me that relationship more clearly than anything else I can do. This leads us to the next point. In orthodontics, we've talked about, you know, in the angle days, molar relationship, and then we got to the cephalometric days of lower incisor to APL line or lower incisor to mandibular plane. All those things tended to drive the plan for us as orthodontics. Well, in contemporary orthodontics today, it's the upper incisor that drives the plan. The position of the upper incisor horizontally, vertically, that drives the plan to me on our positioning of brackets, teeth, and all that. So methods to improve smile arc. Bracket placement is, of course, the #1 thing. Standard approaches to bracket placement. Well, we get all our systems, you know, our prescriptions, and each one of them says the slot needs to be so many millimeters from the incisal edge or whatever. But here's the point, is that you take out this tire tool and you put it on there by, according to the instructions, same patient, same thing, so that you saw the variability we have between individuals. The other thing that I've noted in these sort of instruments is, depending on the angulation you hold it at, can vary where you put the slot. So there's a lot of things inherent in that that are not particularly good. Well, this is a patient that saw me in 2017, and the rationale for bracket placement here is a little beyond me. You see that the brackets are put down on the incisal edge, which then does what? Because you've got torque built into that pre-selected straight wire appliance that detorques the upper incisor. So when you look at the oblique smile, his upper incisors don't project. We're going to talk about smile projection in a little bit. So you look at that and it just doesn't look right. And the reason has to do with whatever rationale on placement of brackets like that. Well, let's start off with macro aesthetics here. The face. We have 3 choices. One, we can keep it the same, we can make it better, or as has been proven in the 50s and 60s, we can make it worse with extractions on faces that didn't need to have that. Let me use this young lady as an example. She's a patient who came in, and when I looked at her, I looked at her lip proportionality. fairly full lips, lower lip very procumbent relative to the upper lip. Now notice what I'm doing is all this starts with the clinical examination. I don't go straight to the teeth. I don't go straight to the models. Starts with the clinical examination. Ask her to smile, very gummy smile. That's very obvious to anybody. But what's good about her smile? What's good is incisal edge position is on the lower lip. It is consonant with the smile arc, which is something that is good and to be protected. I rotate her a little bit to the oblique view. At rest, you see that she has a little bit of chin deficiency now. You see the procumbency of the lower lip. And when she smiles, you see, again, her smile arc is consonant from commissure to commissure, and that is something we'll want to protect. Profile looks protrusive to me, but it doesn't matter how it looks to me. It matters on how it looks to the mother and the patient. I like to take smile pictures also in profile, which shows overjet, which is something that something that patients will see in their own pictures. Thank goodness for selfies. That drives, their appearance issues. So here are the close-ups of her smile and her intraoral relationships. She has a class 2 dental relationship on the right side. She has moderate crowding, nothing to get excited about. Here she is the day she's showing up for her braces. Now, here's the story. What I didn't know was that when I left the room from seeing the patient as a new patient, her mother said to my treatment coordinator, by the way, she was supposed to get braces on tomorrow and somewhere else. And that I haven't heard one thing today that I heard prior to this time. So in other words, none of these things were even brought up to the patient to consider. So fundamental decision, is she an extraction or non-extraction case? She has a class 2 malocclusion. Her cephalometric numbers may be of great impact to someone. But the important part here is that when we probe periodontally, can you pause this just a second?
Yep.
Yeah, I'm gonna need to pause just for a second. You'll edit that out. Sorry.
Okay.
This raises the important factor that we need to be aware of is altered active and altered passive eruption and the effect it has on this adolescent population on crown height. And where do I put brackets? For example, I take the periodontal probe here, and when I probe, I find that the pocket depth on the laterals is 5 millimeters, which means that altered passive eruption is occurring here, where what I'm seeing is what we term the clinical crown height, not the anatomical crown height, which means that when I put the bracket on, it's not going to be in the appropriate place to protect her smile arc. So when I look at in her smile and I probe, the end of that tip of that probe is where the tooth clinical crown height is, and that the gingival margin would be slightly below that after gingivectomy to get the proper anatomical crown height. Well, that's easy to talk about as dentists in terms, but one of the things I want to do is help them see what you see. That's important. That's what we're trying to do here. So goal-oriented treatment planning. The goals may be treat the class 2 malocclusion. Goal may be to eliminate the gingival display on smile and to protect her smile arc. That's in opposition to the time-honored problem-oriented treatment planning. I do this with digital goal setting. What we do is we take an imaging program, which I have helped develop. And what we do is we go ahead and alter the crown height, like so, to demonstrate gingivectomy to the extent of which that will improve the patient's smile. All right, next is to look at the profile. All right, and the possibility of extraction of 4 premolars and reduction of protrusion. I can take this as far as I want. What I'm going to do is tidy up those little areas. And sometimes with these patients, I'll recommend the possibility of when we have the wisdom teeth removed, that they have their chin advanced to idealize the profile. These are all patient choices, up to them to decide. But if you can't communicate to them in a way they understand, which is the purpose of digital goal setting, then that's important. So here she is the day she gets her braces on. I'm going to go ahead and do crown lengthening now before I even put her braces on, so that I can visualize the appropriate place to put the bracket so that I do not extrude the upper teeth any and flatten her smile arc. They do elect to take out 4 premolars, so with closing loops, and in this case, I happen to like TMA closing loops. I don't want to do anything that uprights the incisor. I want to bring it bodily, but keep it vertically where I want it. And also the TMA delivers less force, which keeps me from overpowering my moment to force ratio and getting dumping, which is something I don't want to do. Here she is finished, and what you see here, of course, is the change in lip proportionality. It's just a little more softened. On profile, her smile is vastly improved. On the oblique view, now it appears that she has a little more chin projection, and some of that is just proportionality, that we have reduced lip projection, which makes her chin appear to be a little more prominent. Now, as orthodontics progresses, what you get the feeling of is that orthodontics up till past few years has been a numbers and an engineering exercise. In other words, we've got angles, we've got numbers, and we got targets, and that sort of thing. We want to engineer the teeth to that position. Personally, I see us progressing to it being more of a three-dimensional art form. In other words, what is it that people want? People want that kind of smile. They want that kind of appearance. Now, this is a young lady I treated, and she's got the right genetic code, and so I just needed to get her teeth straight and stay out of the way of everything else. But that smile snaps. It really leaves an impression on you. What is snap? Let me explain what that is. Scripting, nuances, appearance, and presentation. How you verbally describe things, how you see the small things that add up and make small things big things. Overall appearance, which is macro, mini, micro. And then, of course, how do you present these things and concepts so that the patient understands it? You've gotten a good example of that, but there's some other concepts I want you to be aware of. One is gradation, the other is projection. I'm going to skip gradation for time, and I'm going to go to what I think is really quite important. Not that gradation isn't, but smile projection is one that really sort of gets your attention. Smile projection is checklisted as the AP position of the teeth and jaws, maxillary incisor angulation, maxillary incisor display on smile, incisor proportion, and gradation. You note that I don't go through some explanation right now what smile projection means, because when I show you the case and its end result and what I'm talking about, it speaks clearly to what I mean by smile projection. So this is the young lady I'm going to use as an example. Adrian, looks like any normal child who needs to get her teeth straightened. Just look at her closely and script what's going on. First, tooth proportion. Her maxillary lateral incisors are disproportionately smaller than the central incisors. That is a nuance, okay? How do you describe it? How do you describe the fact that when she smiles, she doesn't show all of her upper incisor on smile? So that is a nuance. Oblique view, again, important. Notice the maxillary incisor angulation, retrocline, the incomplete incisor display, and gradation, which is the change in sizes from anterior to posterior. That is what I call the social view of the patient, because that is how people see each other. They don't see each other frontally very often. They don't see each other on profile that often. Where they see them is in groups, conversations, classrooms, going through the airport, whatever. So checklist of the smile projection. Angulation, they're retroclined, so that gets a check mark. Amount of tooth display on smile, it's incomplete, so that gets a check mark. Tooth proportion, the laterals are smaller proportionately than the centrals. Remember, the central drives the plan, and so that gets a check mark. Obviously, first I'm going to get her to brush her teeth. Now you look and go, well, that's a simple class 1. And so when I lecture to interdisciplinary groups, I try to make important that this is not a simple case, because we understand as orthodontists, because we've got torque issues to deal with, that when we torque the roots, that's going to create stress on the posterior segments and create what you see now is a class 2 malocclusion. How do I prevent that? TADS, headgear, lots of ways to prevent that. In this case, we had her wearing headgear, which she realized that if she can get with it, she wasn't going to get her braces off anytime soon. And that's the battle we all fight in those things. All right. Initial alignment, we're complete. Now we want to evaluate, heading into the ending of treatment, the nuances, the incisor proportion and incisor display. The question is, all right, teeth are small. When do I subtract? In other words, do gingivectomy? And when do I add or add length to the enamel of the teeth? I put the ideal tooth outline over it, and what you see is that gingivant needs to be removed there, and we need to add composite or veneer there. And same for the left side. So go through this with the parents. They say, we got it. Go get everything just right. So I take the brackets off, and what I do is I increase clinical crown height by laser to eliminate the passive eruption, altered passive eruption issue, which gives us more crown length. And then I add composite. And the way I present this is as so. I'm going to add some composite to the length of the teeth. Okay, so that they can visualize the proportionality and how much more aesthetic it makes that smile. Also laser to add a little length, and that's what we want to accomplish. So what I do is after laser, I go ahead and take a crown former, add a little length to the teeth. The right one's a little square. It doesn't have to be perfect. That's not the object. The object is to get the height width ratio just right. There's her smile when I am finished. You see that that smile has tooth proportion. It has complete incisor display. There she is before and after. That is projection. The way I verbalize that will be described in just a second. When you look at her on oblique view, projection of smile. Parents get that tooth is prominent. Here's where I came up with the term. The mother sent me this picture of Adrian. She's a majorette. She's very tall, statuesque, very pretty. And the mother wrote in the note that when she smiles, the parents all say she looks like a lighthouse, whose beam is projecting around the gym. It's stuck in my head. That's what we're talking about, is how the smile projects and makes a statement to someone. It's a little romantic, okay, hard to measure, all right, but you can see it, and that's what we're talking about as our desired outcome. That's her overall appearance. That's so important, and that is that on the left looks more like that on the right. Okay, I've been very brief, and I want to thank you for your attention, and thank Miguel for allowing me the opportunity to talk to you.
Thank you very much. Can I ask you just one quick question?
Yes.
How does, in your opinion, differ the patient from the professional in assessing many of these things? In another way of asking, how do you get to match the opinion of the patient with what the professional wants?
Personally, I think what the patient wants overrides all of us.
Okay.
So if the professional, like if I didn't want to extract in that case, I felt like she was too protrusive, but the family goes, that's the way our family looks, we want that, then I don't mess with it. That's called patient autonomy. In the United States, the patient controls, as they should, by the way.
Everywhere.
Yeah.
Okay. Thank you very much.
Okay. Thank you.
Thank you so much. Take care.
All right.
Thanks.
Thank you. Bye-bye.